So I'll just share a few cases and kind of what's evolved with each of these patients over a little bit of period of time. These cases, I would say, are not the most typical cases, but I'll kind of compare and contrast, where I think UBM probably has the best utilization. It wasn't that long ago we were using, we basically had to put our, it's like, okay, patient, you're going to get your UBM. Let's go down to the dark room with, what is it, Pittsburgh? It was Hiroshi Urikawa. It's kind of like a little mad scientist, and they put you in the dark. You lay down. We put this plastic cup in your eye, and it was a rather. We used to make all the residents do it just so they could appreciate what a UBM was like, and they learned to appreciate it. It was not a trivial exercise to ask the patient to go through a UBM. Now, using the Quantel device, it's something we have a very low threshold for doing. So I do it for every patient I see with narrow angles. I think it's a great tool to basically explain to the patients their actual anatomy and say, hey, we have to do a iridotomy for your eye. I think it's a great patient education tool, and it's something we can do in just a couple minutes. It's very quick to do. It's, as we alluded to earlier, it's very patient-friendly, so we don't feel bad about doing it. So we do it much more frequently, probably a couple times a day now in clinical practice. Okay, first case. A 65-year-old woman who's with chronic angle closure glaucoma, had a trabeculectomy, and was just a routine trabeculectomy. Post-op day 1, pressure was 5. Chamber's a little bit shallow, but things were working. Post-op day 3, we saw him again before the weekend. A little bit more shallowing, and the pressure was starting to rise. So I said, okay, maybe some scarring's going on. Performed laser suture lysis. Here's the UBM images. On the first day, we can see there's some shallowing. We can appreciate there's some shallowing of the anterior chamber. Let's see what happens. Post-op day 5, chamber's getting much more shallow. There's starting to be peripheral iris corneal touch. The bleb was not filtering, and the pressure was rising rapidly. We couldn't identify any choroidals. And this is the anterior chamber 2 days later after that prior image. And when you see this, here where the iris is really just flattened up and the ciliary body is kind of rotated like this, this is really pathognomonic for malignant glaucoma. So I think for when you have these patients that you're really wondering what's going on, if you see this, we don't have to wonder anymore exactly what's happening. When you have this loss of chamber, kind of this squashed up appearance of the structures against the cornea. So we treated her as a malignant glaucoma case. We did an iridotomy, because one hadn't been performed before. We basically put her on atropine, some cyclogel in the short term, aqueous suppressants. Unfortunately, the patient was phakic, so despite our best attempts to kind of work peripherally, lasering, it didn't work, and finally they had to have a vitrectomy performed. With a vitrectomy, which is kind of the definitive go-to treatment to basically make the eye unicameral, the anterior chamber deepened, the IOP reduced to the mid-teens, and actually the patient had a successful post-operative course with kind of resumption of a normal anterior chamber depth. But I think this is a case where, especially these malignant glaucoma cases, which do occur with eye surgery, especially glaucoma surgery on a regular basis, it's really nice to be able to get the decision earlier. Often the view's not so good. You're wondering if there's peripheral choroidals, and this really helps to make the diagnosis quickly and move to the definitive therapy. Okay, tubes. So 41-year-old guy, had a lot of CME, vasculitis. He's been treated with steroids, and he's a steroid responder, so he had really high pressures. He underwent 1 tube, got his pressures down moderately, then he needed a 2nd tube. So he basically had 2 tubes in his eye. But then and it was good for about 6 months, and then we couldn't find one of the tubes. He's starting to get some cataracts from all his steroid therapy, which he needed for his macular edema. And so we decided to reposition the tube. Here we can see, over here, this is 1 tube. It's kind of stuck in the iris, so that's the inferior tube. Superior tube, which is right up over here, is not visible. There we go. So we basically found a tube, which is right here. This is after cataract surgery. And our decision was, well, we still have a short tube to deal with. We could use an extender, but we decided to basically reposition it more posteriorly and place it in the sulcus, which is actually my preferred position for tubes because there's no way it's going to hit the cornea and cause corneal decompensation. But we were a little bit nervous because we're taking this relatively short term tube. We re-beveled it and we placed it more posteriorly from this entry point back to here into the sulcus. And the nice thing with the UBM, we could confirm that we were in the exact right position. And like I said, for primary surgeries, if patients are pseudophakics, this is where we prefer to place our tubes in the sulcus. I think it's a very safe, easy place to put them. Here we see the anterior surface of the IOL. This is what we want to sit on top. We have a bevel, which typically, if it's a primary placement, we'll do a reverse bevel to keep the opening away from the iris. But here we see very good placement. The IOP remained under good control, and this was a nice, relatively easy fix for this patient. And his IOPs were mid-teens off of glaucoma therapy despite being bombarded with continuing steroids. So very nice placement. Like I said, I think, we hear a lot of all these minimally invasive glaucoma devices. I think it's very helpful to assess these things. I do a lot of ASCRS mini shunts. My tubes are all in the sulcus. I think with glaucoma surgical devices, it's very nice to be able to ascertain the correct position if there's questions about function or if you just want to see them better. Okay. Last case. And this is this case I would say is a little bit more typical of how we use UBM on a daily basis. 75-year-old woman came in for decreased vision and glaucoma. And she was noted on exam to have narrow angles and perhaps a plateau iris configuration on gonioscopy. Pressures were relatively high on a couple medications, and she had fairly dense cataracts. Here's the appearance of her eye. It's a little bit hard to tell without a slit beam, but her anterior chamber was somewhat shallow. She has a dense cataract. Here's gonioscopy, and you really can't see any angle structures. Just kind of a hint of Schwabe's line with some pigment on it. So she had an anterior segment OCT for comparison purposes, which does give us the hint that yes, she has very narrow angles and a big lens. Here's her UBM though, and it basically shows us her angle, but also most importantly, it shows us this anterior positioning of the ciliary body. And so still the treatment, whether it's narrow angles or plateau iris, is still to do a PI first, so we did that. And it really didn't make much effect. Didn't really see a change on gonioscopy. When we did the UBM, we see that, once again, while we have a hole in the iris, this area of the angle is still compromised, once again, from this anterior rotation of the ciliary body. So we decided to take out our lens. At the same time, we did ECP. Here's the endoscopic view of the back of the eye. The iris is kind of hyperinflated here, but we see this kind of anterior knuckling of these anterior aspects of the ciliary processes endoscopically, and what we do with the ECP is basically shrink this anterior aspect. Our goal here is not really to decrease aqueous production, but really change the anatomy, so that's what we did intraoperatively. And so here's our gonioscopy a couple weeks post-op, and we can see it's very easy to visualize trabecular meshwork now with scleral spur, maybe a little hint of ciliary body there, but obviously a much more open angle. And just to illustrate the value, this is a series of her with variable iris dilation, but the difference, here's post LPI, doesn't really do much for plateau iris, and then post ECP, we see that we've basically truncated this anterior aspect of the ciliary processes, and the angles open and will no longer be compromised. This picture has a little dilation to the iris, but it shows you the value where stopping at a PI is not going to be adequate. We need to do either iridoplasty, or I often prefer to do ECP on the ciliary processes. Her outcome, her vision got a lot better, her angle was much more open, intraocular pressure was basically fixed by removing the plateau component and the lens component, and she's on mid-teens for a number of years and really is just followed as a routine patient at this point. So I think all these cases, in a surgical glaucoma practice, I think UBM is really essential, but once again, anyone who sees a fair number of patients with narrow angles, I think it is extremely important to differentiate whether they have plateau component. And it's one of these things, like the more you look for it, the more you see there's a lot of plateau iris out there where stopping at doing just a laser iridotomy, it will be inadequate in some of the cases, and they're still at risk for angle closure components later on. And thank you very much.